from Microbe TV. This is Office Hours for Wednesday, January 3rd, 2024. I'm Vincent Racaniello, and Happy New Year, everyone. Our first live stream of 2024. Hopefully one of 4 a month. I mean, how many? 4 times 12, 4 times 8, 48. Yeah, there you go. I'm good at math. 48 for the coming year. Tonight we have a special guest. We're going to be here for just 1 hour, folks. The whole stream shuts down after an hour. And so you need to get your questions ready and efficiently presented. From New York, Daniel Griffin.
Hello, everyone.
Hello, Daniel. Thank you for coming tonight.
I was going to jump in on your math there. Isn't the plan to do one a week for these office hours? And aren't there 52 weeks in a year?
I multiplied 4 times 12 months.
Yeah, so some of the months have a little bit extra.
Oh,
right?
okay. Yeah, so maybe it's 52.
And it's a leap year. It's a leap year, so hey.
I was never good at math, I have to say. So I did science that didn't require math.
Okay.
Anyway, Daniel, what do you have on your bow tie tonight?
This is Ebola. People may remember that I was actually in Uganda 2022, December, so a little over a year ago, when that Ebola outbreak was going on. So.
Oh, okay. We have an Ebola painting in the incubator, as you know. Oh, you've seen it.
Yes, it's beautiful. Person. Yeah, people have to come visit and check it out.
Today we had a visitor at the incubator from Bozeman, Montana.
Oh, that's a beautiful spot. I'm thinking, is it a guy who likes to write books, maybe?
No, it wasn't David Quammen, no.
Because doesn't David live up in Bozeman?
He does. He lives in Bozeman, yeah. It was someone else whose name, I'm sorry, is escaping me now. Unfortunately, he's not listening because he's out and about New York City.
Enjoying New York.
But thank you, everyone, for your birthday wishes. Yes, yesterday, January 2nd, was my birthday. And thank you all for wishing it. And Happy New Year to everyone. And you too, Daniel. This is our first recording, right, you and I, in the new year, correct?
It is our first recording. Earlier today, we recorded a PUScast, infectious disease PUScast. So that'll be rolling out. And I know earlier today, Arturo Casadevall was on a recording of Microbial Matters.
That's right, with Mark Martin, who's on the stream tonight.
Oh, that's great.
Let me thank our moderators for this evening. Frank is here, Steph, Andrew, Les is here. Tom is here. Thank you all for coming and helping out. Only an hour tonight of your work is required. The reason it's an hour is Daniel and I need to record the weekly clinical update afterwards, and I'm away tomorrow and Friday at Princeton working on the textbook, so we thought this would be a good way to do it. So let's jump in. You should have plenty of questions, especially if you're from Florida, folks. Let's see if anyone picked up on the Florida stuff here. I'll scroll down. Here we go. New York City Cohen. Do we know why Paxlovid leaves that metallic taste in your mouth?
I don't. But, I think it's one of those things I've noticed that if you ask people, people do notice it. I had it myself. I don't know if I would have noticed it if I hadn't been sort of prompted and looking for it. Some people, it can be quite bothersome. I sort of barely noticed, but I do not know the mechanism. So if we have any biochemists, any physiologists, I'm not sure who would actually be the one who sorts this out for us, but not sure.
Is it the ritonavir component, Daniel, or is it both? Do you know?
So the reason I don't think it's ritonavir is that we've used ritonavir now for probably, let me just do the math, 10, 20, 30 years, so almost 30 years, right? So it was ritonavir was initially a protease inhibitor itself, but then it actually became a pharmacological enhancer. So we've been using it for 20 plus years. You never get that. So it has to be the nirmatrelvir part of it.
Okay, here we have one from Rima. Does an agglomeration of viruses have a smell? Do they participate in the unique smell of an individual or smell to dirt like some bacteria?
This is a good question. I know this has come up, and we've historically said no. That when, like for instance, the canines, right, are doing the detection, we've always said it's the volatiles. They're not actually smelling the virus; they're smelling the volatiles. So, when a person starts to get sick, they have a different smell. I remember certain clinicians who seem to have an uncanny accuracy with smelling strep throat, and then that later confirmed with the rapid antigens and cultures. So I don't think we think this is true. Vincent, is there any examples of we get enough viruses we can actually trigger?
I'm not aware of any, but I think, as you said, the bacteria make volatiles that smell, right?
Mhm.
This is not the bacteria themselves. So a virus particle doesn't make a volatile. Certainly some viruses make volatiles in infected cells. For example, there's a virus of aphids. The aphids deliver the virus to a plant. The plant cells make volatiles that attract more aphids.
Yeah.
So if you're an aphid, Rima, yes.
Yeah, but I don't think the physical virus will
I don't think so.
bind to a receptor, cause a sensation, an experience of smell.
I used to purify buckets of poliovirus, pure on cesium chloride gradients. It didn't smell like anything. I did sniff it.
So I never did when I was making viruses in the lab, right? You could actually see like a pellet. You
Yeah,
had that
yeah,
much virus, and
exactly.
but it was always BSL-3 or so. So it was always, I was always careful, never sniffing.
Here's Mark Martin. Welcome, Mark. Thank you for birthday wishes. And Mark interviewed Arturo Casadeval today, and Arturo is going to come on Twiv, Mark, for a deep dive into his new book. I'm sure you talked about it.
It's the book with Ferric Fang, right?
Yep.
Fang.
Yep.
Yeah.
Yep. Ferric Fang. Okay. Are there data available to recommend one RSV vaccine over the other?
So, so May, right? So spring of 2023 is when we get approval on the two different vaccines. One of them also has the extra approval for women last trimester. Um, if you look at the studies, they were not head to head. You can compare the studies. I think now that we have the post marketing safety data, both vaccines highly effective, both vaccines very safe. I don't really think there's any compelling science out there to push you one way versus the other. I know people early on were sort of like trying to tease apart non-statistically significant signal, but no, I think I think that one or the other get that vaccine.
And if you go to CVS, you're going to get one.
Yeah, and that's just a contracting issue.
Yeah.
Yeah, but I would say, I mean, thanks for bringing up RSV vaccines because over the last few weeks, I think we're coming off the peak, and we'll talk about that on our update. But really, a lot of RSV hospitalizations, RSV deaths, during the peak this winter, and so many of those could have been avoided.
There's another one from Mike. What were the safety signals in the vaccines, and what follow-up data are available?
So the neurological complications, right? That was what was concerned. There was some signal, and it was a little challenging because some of the signal came out of Africa. We weren't really sure. Did they really have the diagnosis that was suggested, or did a clinician just sort of suspect? And then later on, it wasn't really confirmed. So there was a acute demyelinating encephalopathy that was suggested. There was a Guillain-Barré suggested, but now we've done millions, and nobody, no reports, no, stop the buses here. Some expression that I'm not good at catching, but no, we're not hearing any reports from the vaccine adverse event reporting system.
Kang writes, and you remember Kang? He took us out to dinner in Chicago.
Kang, hello.
So, guys, if you want to get us to remember who you are, take us to dinner. No, I'm just kidding. We remember all of you. All right. If viral shedding damages infected cells, how can anyone shed a transmissible dose of viruses without any indications of infection or symptoms?
Okay. Okay. So this is a good one. You and I we'll tag team this, Vincent.
Okay.
Um, So, there's this word shedding, and it's really interesting because it comes up all the time. Let's say an individual had COVID-19, they got admitted, whatever happened. Now it's like 22 days later, they end up in the hospital. Someone does a PCR for whatever reason, and then the nurses want to know, oh, does this person have to be isolated? Are they infectious, or are they just shedding? And I'm not sure I know what to do with the word shedding. Like, what exactly does that mean? But let's just talk a little bit about the time course and what happens with SARS-CoV-2, right? So that first week, lots and lots of virus. You put a Q-tip up there, and you are talking about millions of nucleic acid amplifiable units. And then, you might continue to get a positive signal. And sometimes we've even seen some of these curves where the signal seems to go down and then it looks like it comes up. Also, during that second week, as we've talked quite a bit about, there's a lot of shedding of cells. And when you're swabbing the nose, you're not swabbing mucus. I think people miss this. You're not swabbing mucus. You're actually getting cells. You're getting intracellular, if it's an antigen test, protein. If it's a nucleic acid amplification test, it's going to be RNA. And you're getting more of those cells off. So this is not a blood test like we have with HIV or EBV or CMV or the other viruses, where you're really actually getting a quantifiable amount of virus per unit blood. A lot of it has to do with how many cells you get on that Q-tip, how many cells actually have genetic material in them. Doesn't necessarily mean that these are viable, replication competent virions.
Well, I think, of course, it depends on the virus. Some viruses can reproduce without damaging cells. So, like paramyxoviruses can do that. But I think also that if there is sparse infection of the nasal mucosa, it's not all clustered in one place. You could have efficient replication and shedding without having any clinical symptoms. But I think we don't know. It's a good question because it clearly happens. There are clearly people who shed virus and can shed a lot of virus and don't have clinical symptoms. But
Yeah. I mean, I was thinking like moving from viruses, like Giardia, of course, comes to mind, where, a small fraction of people actually get really, really sick, right? Like they have fever, they have chills, they have systemic symptoms. But there's a lot of people where the Giardia replicates and kind of does its thing, and probably part of the transmission chain, but not being sick. And yeah, I mean,
yeah.
if the virus is just replicating on a mucosal surface, but it doesn't actually trigger fever, the pyrogens, the systemic response, you don't feel sick. You feel fine, but
Yeah.
you still can be part of the transmission chain.
Well, it could be that the virus is suppressing the sensing, and so you don't get any of the inflammatory response, right?
Hmm.
So there you go, Kang. Okay, John wants to know if we've found any genetic markers for severe outcomes with COVID.
Yes, there's been a lot of work in this field. There was this sort of back and forth about some of the blood types, right? The group A, the group O, and then it's sort of back and forth. We don't think the blood markers themselves, but it looks like there's correlates. Also, some other work doing these studies where they look at certain cytokines. So yeah, there is some work going on, and we certainly saw early on. Clustering in families, right, where families would have worse
Yeah.
outcomes. We've certainly seen different ethnic groups have worse outcomes. Native Americans, right, one of the highest death rates. So there not only is there a lot of say epidemiological evidence to support a genetic background, in addition to, don't forget, our socioeconomic situation here in the U.S. But yeah, there's also more and more work on the genetics behind severe COVID outcomes.
Of course, the big factor, which is not genetic, is age, right?
It's really crazy, but age is one of the biggest, actually.
And having antibodies to interferon is another one. I would say that's probably a genetic marker of some kind, right?
Yeah.
That's a bad one.
Yeah.
All right. Olaf has been writing about mistakes made during COVID. What would you consider to be the biggest mistake made during that period?
In all honesty, what was the biggest thing? I think that we did not put enough effort into education. Right. I mean, I understand our model of like a free press and all the rest, and we spend money on certain things, but I do not feel like we spend enough money on education. People were locked at home. They were desperate to understand. There was a vacuum. People really wanted to understand stuff. We tried. We stepped in. I'm not sure that we had as many ears and eyes. Watching TWIV. And
Yep.
unfortunately, that vacuum, that educational vacuum, was filled by other voices, by entertainers instead of edutators, instead of educators. So I have to say, and I think we're gonna suffer if we don't really ramp this up. We've been talking about malaria vaccines, right? Tremendous tools. If we don't spend the money on education so people understand how valuable these tools are. We're seeing it now with the antivirals. The vast majority of high-risk individuals do not get offered a therapy that can reduce their risk of progression by 90%. How is that happening? And again, it's lack of education. So you can pick little things out, this and that. Why did we go with mandates instead of education? I think, my one thing, and I'll probably keep repeating it over and over again, is the best thing is education, open, honest communication. Vincent?
Yeah, I agree. I think there's a failure of communication. That's what Paul Offit's talked about. He's talked about emergency use authorization. He's talked about Operation Warp Speed. And today we recorded him talking about breakthrough infections. So all these bad terms that were used and really messed
Yeah.
things up, right?
Yeah, and like breakthrough. I read that recent article by Paul where he talks about the poor choice of words with breakthrough infections, and people, oh, but this is what we've always used. That's the term. It does not need to be the term. Once you realize you're in a pandemic, you realize, like we did with Mpox. You don't call something by a name that is misleading, right? It suggests failure, and so that's an educational problem. So we've always tried. I know I've always tried to call them post-vaccination infections. That's
Yeah.
what they are. It's descriptive. There's no failure.
Yeah.
We talked about polio as a model. That's what you want you want your infection to come after vaccination so you don't end up paralyzed. You want your SARS-CoV-2 infection to come after vaccination so you 90% reduction in a severe outcome, turning the wild into mild. Why the slogan of turning wild into mild? Why did we not come up with that until after we had gotten through the worst of the SARS-CoV-2 experience?
Okay. Pablo writes, we see evidence for increased susceptibility to severe disease upon repeat infections with SARS-CoV-2. Is this unique to SARS-CoV-2, or do we see this for other viruses?
I guess I'll start with the
Influenza?
first. Yeah.
In,
Oh, yeah.
inf-
Did you want to?
no, do you see it with like influenza? Do you get severe disease on subsequent infections?
So not necessarily, and I think it's that there's different influenzas that are associated with worse outcomes. Right? When we first saw H1N1, it had been a while. We saw worse outcomes than we had seen with others. Um, often with exactly the same flu, if you get it the first time, you get it the second time, it's often not as bad the second time. Um, Dengue, right? Dengue is the classic. We always say that the first time isn't quite as bad as the second time. I mean, there's some subtleties there, but no, the antibody dependent enhancement. So dengue second infection is associated often with the worst outcomes compared to the
Mm.
first. So yeah, I think we've sort of evidence of both. We have certain infections where that first time sort of sets you up in a better position for the second time. Dengue is the classic where that first time can really set you up, particularly if it's a different serotype. You get dengue, say type 1 or 3, and then the next time you get dengue type 2. And I mean, I had that personal experience.
Mm.
Where I got an initial dengue infection in Southeast Asia. And then several years later, I got another dengue infection. And that second time, I was in the hospital, platelets in the single digits, felt like someone had broken all my bones.
Hmm.
So, yeah.
All right. Visto says, people around me getting blocked ear post cold like symptoms. Does this anecdote match a virus known to be going around?
Blocked ear post-COVID. So we are, so one is I will say we are certainly seeing eustachian tube dysfunction as a
Mm.
post-COVID manifestation. Just a lot of inflammation. People having to use things like Mucinex, guaifenesin, things to try to help get that eustachian. But there's so many co-infections going on. I was talking the other day about, Hickham's dictum, right? You can have as damn well many things as you please. And, you see people coming in with one of the common coronaviruses and RSV, or SARS-CoV-2 and RSV, or flu and COVID, or flu and RSV. And so there is so much going around right now. Apparently, in the UK, they're having a massive issue with scabies, and so someone was joking about it. It was scabies, immune deficit, or whatever that invented terminology was.
Hmm.
Immune debt. We haven't had enough scabies, but yeah, there's a lot going on.
Here's Jamie, who visited the incubator today. Thank you, Jamie, for coming. I am in. He's watching still. What a devoted fan. Thank you very much for
He's
visiting us.
responding to the taking us out to dinner request. I think that's what I'm taking from your comment.
How after Babel writes, any news on oral remdesivir and new antivirals?
Yeah, so we talked a little bit about some further research on the Chinese compound, right? Which is the oral once a day times 5 days. Seemingly similar to Paxlovid, kind of an oral remdesivir idea. There's also Shiogi Pharmaceuticals in Japan. So there are several other antivirals out there, but I think one of the things we've got to sort of ask is there going to be a market for this, right? We have Paxlovid with great data, but of course being targeted by the anti-science community really successfully, to the point where you have folks that went to medical school believing rumors of rebound, when we've really gone through the compelling science and the NIH recommendations for that. Yeah, it would be great to have other options. A person might have drug interactions, other reasons why Paxlovid might not be right for them. So it would be great to have other drugs in the class.
Look who's here. Amy Rosenfeld. Hello, Amy.
Hey, Amy, I got a bunch of emails in my inbox. I haven't responded, but I will.
Okay. John wants to know how much progress towards the match so far. How many years have you been going to Uganda? And are donations to PWB the best way to support philanthropy there?
Yeah, so I always like people to continue to donate, but even if we're not quite there, I always throw in a personal donation to get us to the 20K when it comes to microbe TV, because microbe TV is near and dear to my heart. When did I first start going to Uganda? Had to be like half a dozen years ago. I had worked with Foundation International Medical Relief of Children in the Dominican Republic, and then later by up on the Haitian border, like a stone's throw. And then I started going to Bududa pre-pandemic, actually just back there again last month. We're trying to figure out with Foundation International Medical Relief of Children, is there a way for them and Parasites Without Borders to participate in the malaria vaccine initiatives, which I think are super exciting. And interesting enough, education, relationships with community members, donating to PWB is a great way, just because we have personal connections, we know people, we can make sure that the money's actually going to where it should go. PWB doesn't pay any of our directors or anybody, any money. It just all goes to our mission, to education and everything else we do.
Did you know that January 2nd, my birthday, was also Isaac Asimov's birthday? I
am
know.
a huge Isaac Asimov fan. Not only did I read like all the Foundation books, but there are these rare like single printing books that kind of go in between the major books, and I have those and have read them.
Good. All right. Frank wants to know, is one of the after effects of COVID constipation? Frank, too much information.
Okay, you're talking to an MD here. I was seeing a patient today, and I was reading one of the other doctor's notes. I was like, did they really discuss all those things with you, or did that just get cut and pasted in? They just laughed. But COVID can actually have significant impacts on the GI tract. And we've talked a little bit about this where I've had patients just have like uncontrolled diarrhea, really horrible, debilitating. Also, constipation is another manifestation we see. Talk to your doctor. We definitely have ways to help people. Almost easier to help with the constipation there, Frank. So to be frank.
Frank, well, I know he's talking to an MD, but you got 240 people listening in as well.
Okay.
But speaking of 240 listeners, that's just great. We have 99 likes, 100 likes. Please hit the like button, okay? It helps to get other people attracted. And as we've been saying, we need other people to be listening to our message here. Okay, what's up next? Let's see. Question on Shingrix from Nicola. I'm 42. I've noticed a couple of my friends around my age already had a flare-up of herpes zoster. Wouldn't it be better doing the vaccine in the 40s instead of waiting at 50?
It is interesting. People make these decisions, right? Like 50. Why that round number? Why not 47 in 3 months, right? If you look at the trajectory of when we start to see the increase, it actually starts to go up in the 40s, really 50s, and then goes up. So it's a public health comment to suggest that people start getting the shingle shot at 50. It's a fully licensed vaccine. If you have a discussion with your provider and you want to jump in earlier, reasonable to have that discussion. These random lines in the sand at 50.
Okay, Lise is now talking about the elephant in the room. Just saw the Florida headline. Florida Surgeon General calls for halt an mRNA vaccine. What the heck?
Yeah.
Indeed.
Yeah, one of my colleagues, Wendy, sent me the link today about that. Vincent, you want to comment first, and then we'll go back and forth because, I think this is important to discuss because there's going to be conversations. It's probably good for us to educate and discuss talking points. So,
okay, so the Florida Surgeon General claims that there is a DNA contamination, small pieces of DNA in the vaccine, which is true, small amounts, but every other vaccine also has DNA. Even Novavax, which he said you should get instead, has DNA in it because it's made in insect cells, folks, Dr. Surgeon General. So what's the problem? He says it's going to integrate and cause tumors. There's zero evidence for any vaccine doing that. So this is just, what is it, a political move, Daniel?
So I suspect it's a political move. It's a sort of a tribal thing. And he's doing that classic anti-science, which is where you say, a lack of evidence. No, you've got to prove to me that this doesn't happen. And I'm not understanding how that's supposed to happen. So, if you read his statement, which was sent my way, he wants the FDA to somehow acknowledge there needs to be further study until he's satisfied. He's going to continue to look into the mRNA vaccines. They're even in the same sort of conspiracy theory, and it's kind of a lot of what this is. This is not science. This is not people having a scientific discussion. This is people with an agenda looking for fodder to back their perspective. They talk about the 1-methyl pseudouridine and frame shifting, and a lot of this sounds scary until you actually talk to people who know the science, right? And so RNA is a moiety that there's lots of. mRNA is a natural part of our cells. mRNA all over the place. DNA is not some scary thing that is going to somehow, just waiting to integrate into our genome. And then, a lot of the modifications, the modified mRNA, the modified messenger RNA, it's modified in really a pretty similar way to the way we modify ourselves, our mRNA, so that it doesn't trigger this massive immune response. So I think a lot of this is misguided. I think we have to be a little careful as MDs, not thinking suddenly because we went to medical school, we're molecular biology specialists. And this gentleman is not.
Yeah. I think the key here is that every vaccine has DNA fragments in it. So why are you picking on the mRNA vaccine? So
Well, I think he's picking on it for, he was given this job by someone who has a political agenda. He is a political appointee. He was not
Yeah.
like all the doctors got together in Florida and said, who's really the best person for the job? This is politicians said, I want a person who is going to do my bidding. I know people don't like when we get political, but what's happening is the politicians are stepping into science, and where I think that what I'm trying to point out is they're not stepping in with
Mm.
science. They're stepping in with rhetoric. They're stepping in with dishonesty. They're undermining good science. They're tricking people. They're willing to let people go unprotected and die um, through this misinformation, and that's what we've seen, right? We're in a country where we have, over 100 deaths a day. We have thousands of deaths every month. So many of these are preventable. Vaccinations, we have antivirals. Yeah.
What disturbs me is that the Surgeon General of Florida has an MD and a PhD from Harvard. Okay.
What is this? What is this PhD? Do you know, Vincent?
Uh, public health, I believe.
Okay.
Yeah. Public health and epidemiology. But MD. So he doesn't really have training to understand molecular biology, as you said.
Yeah, this would
Nevertheless.
be one of those, like, if you wanted to be some kind of like, expert in the field, they would say, oh, and so, tell me a little bit about your training in, mRNA and, and modifications and DNA integration and how does it,
Yeah.
it's,
Well, the thing is that, I mean, people know that Harvard is a good place, right? It's an excellent school.
I think people have been starting to ask some questions about that recently, Vincent.
Yes, but that's the point. Not everyone that graduates from an excellent school is excellent. So you shouldn't just blanket give people cred if they're from Harvard or Columbia or where are you from, NYU, right?
I did do my MD at NYU, and I would like to think that was an august university. I am, what am I, like the third of four generations. My dad went there, his dad went there, and my daughter's there now. So
Okay, here is Jamie. It was a great pleasure meeting you in person. I'm the visitor from Bozeman. I'm trying to figure out how many viruses we exhale per nanosecond. He actually asked me that, and I couldn't answer it. So thank you, Jamie, for coming. Carol, our favorite nephrologist from California. My friend's mom tested positive for SARS-CoV-2. When is it safe for me to socialize with my friend?
okay, so this comes up repeatedly, and it's good to go through this. Um, there's no zero threshold anymore, right? So we'll talk about your friend's mom. So your friend's mom, this is sort of an easy lift. We ask the question: when did your friend's mom start to have symptoms? And symptoms attributed to the COVID-19, to the SARS-CoV-2 infection. Not as easy always, because there's so much going around. Like, were you sick and then you got COVID, or you got sick and that sickness is COVID? But you pin that down the first 5 days from symptom onset. And the first day, like, oh, I got a scratchy throat on Saturday night, that's day 0. So you start counting. First 5 days is when a person is the most contagious. Transmission tracing, that's when we see about 85% of the transmission events. And then it very quickly drops off, maybe some transmission day 6, day 7, and then very little 8, 9, and 10. So that's the sort of primary person. Then what about the people around them? Now, early on, we did this, be super careful. If you've been exposed to anyone who tested positive for SARS-CoV-2, we didn't wait for any symptoms. You were locked away for 2 weeks, right? Just to be on the safe side. The entire incubation period, even down to that like 1 or 2% out to day 14. And then you had to get tested, even if you were asymptomatic. We've really moved away from that. And so for you, it's a question of who are you socializing with? What was your degree of risk? We're usually seeing at this point in the course of this, where people start to get that little bit of symptoms before they become infectious to others, which is a change early on, right? It was a lot of transmission happened in that day or two before symptom onset. So hopefully that's a long-winded answer. But in general, if you're asymptomatic, you can go ahead and socialize. But then you've got to ask is that friend of yours constantly being exposed? Are they symptomatic? Will they tell you if they get symptomatic? So all the subtleties.
They could both wear masks also, right?
Or hang out outside, right? I mean,
Outside
that's
too? Yeah.
yeah. I mean, one of the things we talked about a study recently where most transmissions are not 15 minutes within 6 feet, right? That was like less than 20% of transmissions are that really, short, close exposure. So if you're with your friend, you're outside, you're a little bit apart, you're not like talking right into each other's faces. What was it? An average of like 4 to 6 hours exposure in a suburban home for most transmissions. So, yeah.
I don't know about you, but I have a few colleagues who, when they talk to you, they're within 3 inches of your face. Do you know anybody like that?
Yeah, I guess I have like a personal space thing. Like that's too close.
I know a couple of people, two would come to mind
Yeah, I
in
still I
particular.
still remember what was it, end of February, and you and I and a third person who we won't mention at the moment. We were doing a recording, and I made sure that we were not only 6 feet apart but facing different directions. I don't know if you remember
Yeah,
that.
I remember
And
that.
then that third person who remained nameless actually turned it up testing positive the next day. So
So much for that. Yeah. All right. GSD Bio says, I'm curious about something that's come up a few times about high frequency vaccinations and whether constantly raising antibodies could represent a significant biosynthetic burden. I'm skeptical.
it is interesting because we in the world, like forget about vaccines, we're constantly being exposed to different antigenic stimuli. You look at people who live in Africa, right? I mean, you get malaria like all the time, and actually that constant level of premunition actually is keeping people safe, and they're doing just fine. We as clinicians, I talk about my pediatric colleagues, they are like always being exposed. It's like a daily vaccine with like who knows what that walks in the next day. So this whole idea that somehow the vaccinations are going to create some biosynthetic burden, I'm not sure it really makes a lot of sense.
We have a contribution from Kip and Laura, two PharmDs from San Francisco. Thank you very much. Laura reports CPMC ED is half full with respiratory patients and is increasing.
Well, hello, you guys. Nice to they came and visited us, if you
Yep.
remember, Vincent. And only half full. I have to say, our local emergency departments are completely full, and beds are in the hallways, and lots of respiratory
Yep.
infections.
All right, John wants to know, does EBV reactivate after COVID for some, and is that a post-acute sequelae? If so, since most get EBV, is there any rhyme or reason as to who will, I guess, reactivate?
So we have a few studies looking at this, and I'll not go through sort of the two types of studies. So a few studies looked in the first 2 weeks, people hospitalized with acute COVID, and what they did is they did EBV DNA assays to say, are we now going from a latent virus, usually you can't detect it, to a positive EBV test? And one of the studies, remember, 40% of the folks in the hospital actually had EBV DNA detectable, so pretty high level. Then we had other studies like that, but then we had the Yale Mount Sinai cohort study where they came together, and what they were looking at is they were looking at very high serology levels as evidence of reactivation during acute COVID, and they were looking at folks that had long COVID more than a year, right? So real long COVID that was persisting. And a significant chunk of those individuals have really high, like let's say the test is above 21 is positive, and you're talking about people with greater than 750. They just off the scale that they can even measure. And that's something we're certainly seeing in a lot of our long COVID patients. So yes, EBV does reactivate, I'll say during acute COVID in some individuals. There's this statistically significant connection with post-acute sequelae. Why some people? Why not others? I don't know. Talking to a lot of my long COVID patients, and at this point, it still hasn't gotten to the point where we have like a number to put on this, but a lot of them actually remember having symptomatic COVID in high school. So it'd be interesting to know, is that a marker? What really is the rhyme or reason for who gets EBV reactivation? But there's a connection here.
Will wants to know, in the last clinical update, Daniel reported about efficacy of azuvudine. Is it being used in the USA? And if so, what's the price?
So this is the Chinese. I think it's like VV116. I forget the little, less memorable letter number. But this is that 5-day, once a day oral antiviral that they're using in China. So not here in the U.S. So no price.
Abdulaziz, thank you so much for your contribution. Skip the clinical update. Well, a lot of people like to hear it, Abdul. I know you'd like to hear us here, but thank you very much for your support. All right. Nebi says, have the timing of symptoms in a positive rat following exposure changed in the past 2 years with variant change? Lots of new cases here in Florida. And I get your reference. I'm embarrassed for us who live here.
So Nebi, there has been a change over time. As we talked before, it used to be, and we did that like Let's Get Back to Work program where we were testing for. Originally, it was Lionsgate, and that was Amazon Prime, the other studios, where we would test everyone end of the workday, 5 o'clock. Everyone got swabs. The swabs were like getting loaded on planes at Triborough or Teterboro, and it was Teterboro, and then
Teterboro.
Yeah, not
Triboro's a bridge.
Triborough Bridge. And we were picking up people before they got symptomatic. We had no failures. It's sort of amazing, right? We also had like similar stuff we did with the NHL, where testing asymptomatic people, catching people before they got any symptoms before, hopefully they would transmit. Then we started to see, and this seemed to really correlate with vaccines, pre-existing immunity, people starting to get symptoms first, and then afterwards you started to get your positive rapid antigen test. That has changed over time. So you have your exposure. You have a shorter time from exposure to the onset of symptoms. It used to be 5 or 6 days, and then it came down to 2 or 3 days. And then, with the positive rat not becoming positive until after day 0, so day 1 or 2, getting those positive. So, yeah, there's been a change. I don't know how much of it, in all honesty, tracks with variant so much as it tracks with the immune response and the pre-existing immunity.
Marco wants to know, in your geographical area, are you seeing people getting sick with something else after recovering from COVID?
So we still see, and when we talked about the stages, right? So you got the viral, you've got the inflammatory, and then some folks at the end of that inflammatory will get a post-viral infection. So sometimes they'll develop a sinusitis. Sometimes we're actually seeing pneumonia after that. So there is some sort of impact and an increased risk of bacterial infections, and that's sort of end of week 2 into week 3. And we've seen that for quite a while. We're still seeing that.
Ariozone says, are there alternatives as effective as Paxlovid for someone who's dependent on benzodiazepines?
So the first thing I'll say is not all benzodiazepines have an issue with Paxlovid. So if you go through, you can see that there are certain ones that are compatible. So if your provider is savvy, and as we like to say, if you have a plan ahead of time, you potentially could have that ability to switch from one benzodiazepine that interferes to the other. Remdesivir, right, based on the Pine Tree data, that's IV, 3 days if given in the first week, is similar efficacy in the studies to Paxlovid at preventing progression. There's molnupiravir, and molnupiravir is really like second choice after Paxlovid, remdesivir. It's not as effective.
Susan wants to know if it's odd to have metallic taste for 4 weeks after the 5-day course of Paxlovid.
Yes, it is. So I'm sorry, Susan, because I'm suggesting that maybe you are experiencing that. So it's very uncommon that people have a prolongation of the metallic taste. What is probably happening is this is probably not the Paxlovid. This is probably the gustatory disorder that follows COVID. So we've seen this, unfortunately, since the early days. People develop an issue with smell and taste. Sometimes everything smells and tastes like feces. It really, it's not a laughing matter. It can really have a negative impact on life. We have people lose significant amounts of weight because they just everything smells and tastes. I mean, can you imagine eating and having that horrible metallic or that fecal or that sour bitter? So this could be really difficult. People wanting us not to do the COVID clinical update. I'm going to be talking about a meta-analysis looking at studies that analyzed a particular therapy that might be helpful in people with olfactory and gustatory disorders.
A number of people have asked, and I haven't read the questions, but here, if new antivirals are around the corner.
Yeah, so I don't know if the new antivirals really are around the corner, right? Because there's this whole process, costing millions of dollars to get antivirals approved, and then marketing, getting people to know they're out there, and then getting providers to prescribe them, patients to use them. This issue of giving a travel prescription for Paxlovid. Providers seem a little bit like either side on this. Vincent and I, we talked with a social media influencer early on who was talking about racial disparities and who was getting access to Paxlovid, who was getting access to Paxlovid for travel, even while it was still under EUA. It's licensed at this point. The last thing you want to do is have a high risk individual test positive, have COVID, and then not have access to a tool that can reduce their risk by 90%. So if your doctor doesn't like to give you a travel prescription of Paxlovid, I will mention that there are other doctors out there.
Yes. John wants to know, he said, I recall you saying 90% of COVID deaths were people not offered treatments like Paxlovid, and antibiotics are overprescribed. Also 90% for COVID. Has that improved at all?
So the early antiviral treatment is slowly creeping up. It went from this only 10% to 18%. There's a study that I will talk about tonight, but I'll probably talk about on the next clinical update, where maybe we're up to the 31% of eligible patients are being prescribed antivirals. Unfortunately, the steroid antibiotic use during the first week, that's still going on, and it's really painful. I was seeing a patient yesterday who, unfortunately, got COVID, right? We had our telehealth appointment, started him on Paxlovid. A couple days later, started to get a sore throat, went to go see an ENT who started him on steroids and antibiotics on day 3. And he just had a horrible time. He was starting to get better other than the sore throat. And then it was just, as he described to me, the worst 10 days of his life.
All right. So we have a couple of questions about this, about how to deal with doctors who give you wrong information. For example, can you talk about how doctors communicate with each other on a national scale? It seems that there's a lot of contradicting information, treatments, et cetera.
Yeah. So, one of the challenges, and this is a bit embarrassing for our profession, is that we don't really have a great mechanism for effective continuing medical education, right? We have these requirements where people, they go skiing and they sit for like a few hours, and then they go skiing for the afternoon, and there's a few more lectures in the evening that they may or may not pay attention to. And once every 10 years, they cram and pass an exam. We have professional societies with guidance. We have the NIH treatment guidelines. Unfortunately, when you look at surveys, most practicing clinicians are not referring to those guidelines. A lot of them aren't even aware of where to go or the fact that they're being updated. It's a buyer beware. You're going to have to somehow select a provider who is committed to providing you with the best evidence-based medicine. I mean, we have learned so much since I went to medical school last century. So if you're not keeping up, if your doctor's not keeping up, you're providing low quality care, and that's not great.
Basically, everybody in the U.S. needs to use Daniel Griffin, MD, PhD. That's it.
Or my wonderful partners who also are committed to staying up to date. So.
Paolo wants to know, do we know why rebound happens? Does it occur with other viruses? What is the paper looking at how long people are infectious? Are they infectious if they still have a fever?
Yeah, so I want to take the word rebound again. This is going to remind me of Paul Offit. Like, words matter. So it's not rebound. what we have here is we have a viral phase and an inflammatory phase, and we see that with a number of different infections. So, the first week, the virus is replicating like gangbusters. Maybe you've got a headache, a runny nose, muscle aches. You feel crummy. The viral RNA goes from millions and millions, teeming with virus. Who am I quoting? And then the second week, you get that inflammatory surge. And some people feel crummier. It was the second week when people ended up in the emergency rooms and the hospitals. It was the second and third week when people got really, really sick and died from COVID in the early waves. So there's nothing new here. It's not rebound. This is the natural history of the disease. This is your immune system kicking in a little too exuberantly. If we can get that virus down in the first week with antivirals, if we can get that viral replication down by being vaccinated and immune, ready to contend with this, you're going to see significant reductions in the degree, the intensity of that week 2 inflammation. It's not a rebound. That inflammation, that cytokine storm is week 2.
Doreen wants to know if her 26-year-old can now get Shingrix to supplement the less effective chickenpox vaccine she had.
So, not yet, Doreen, but this is actually a little bit of a discussion, right? The Shingrix vaccine, which is not a replication competent attenuated virus like the chickenpox vaccine, which gives you better antibody responses. It may potentially be the replacement. I'm going to draw like the polio analogy out here. Like a certain percent of people that get the chickenpox vaccine, they actually get shingles. They get reactivation. So why are we giving people an attenuated replication competent virus that can potentially later on cause them shingles, which can be horrible, versus just give them the immunity without that exposure?
I'm frozen. I have to reboot. Just a minute. Just take a second while I turn my camera off and you're all by yourself.
Oh my gosh.
But there is a question, a comment here. Here I am, unfrozen. Actually, Remus says the Florida Surgeon General should stop allowing tobacco, cigarettes, and alcohol because these cause cancer. And, yeah, of course.
Well, I think that until they do more research, they should stop allowing tobacco, cigarettes, and alcohol.
Okay, let's see. Could viruses have developed as an immune mechanism of primitive unicellular life to parasites? When you talked about the behavior of that integrated virophage, it sounded like an immune response. I don't know. It's a good question. Maybe, but it would have to be, yeah, it could be because, I think these big, so the story general is that some virophages that interfere with the reproduction of giant viruses are integrated into the host. And when the giant viruses infect them, these virophages are turned on and they inhibit reproduction of the giant virus. So, yeah, why not? It could have happened.
Yeah. No, I that was I think the episode you recorded before the giant virus meeting, right? Where you were meeting with the organizer and talking about
Matthias Fisher.
Yeah.
So N.Y. Cohen said, my dad and my grandfather went to NYU medical school. And his grandfather was in medical school with Salk and sat near him because his last name was Shafirov. I guess they're all alphabetical back then, right?
Yes, that's so funny. Yeah, who did I run into at NYU? It was Kaplan. Stanley Kaplan of all those courses.
Sure.
And he was a little disgruntled because his mother really wanted him to go to medical school and he could never get in, so he did that instead.
In the case of hives, would you stop Paxlovid before the 5th day?
It really depends. Again, this is risk benefit. We're going to be looking at what's the risk does this individual have. Let's say you say, oh, no, this is a 91-year-old with multiple medical problems. Paxlovid is really what's going to keep that individual out of the hospital despite vaccines. How bad are those hives? Is this something where I'm just going to say, take some Benadryl, take an antihistamine, or is it I just can't handle this. How many days into it? The other thing, which is interesting, is do we really, everyone's always like wanting 10 or 20 days of Paxlovid, but is 3 enough, right? I mean, as we saw with remdesivir, first 10, then 5, then 3. So yeah, this would be a judgment call.
So Daniel, we just went over 300 viewers. I have to say you beat Dixon last week.
Oh, okay.
Dixon just barely got over 200.
Oh, okay. I'll make sure I mention that next time I see him.
So is RSV killing as many people as COVID this winter?
No. You can actually, there are these trackers where you can see like how many people have died so far of RSV, have died of flu, have died of COVID. So far, COVID is number one. Flu's doing a pretty good job. RSV sort of had its sprint and hopefully is on the way down now.
Folks, please hit the like button. You only have 170 likes. We have 300 of you here. Please hit the like. It's right below the screen. It's very easy. It doesn't cost you anything.
Does that mean 200 people don't like us?
They're neutral. All right.
They're waiting. They've got 5 more minutes to decide.
MG says Twivin is an effective vaccine that protects against debilitating misinformation. That's really good. I like that.
Yeah.
All right, here's one. Could you please give a short summary of who and when should get COVID booster after 3 doses of mRNA and had no infection?
Okay, yeah. So we've talked about this a few times, and I think this is part of the education, the communication. You want to be honest about what you can expect, and so I like the message, turning wild into mild. So the first 3 doses of the mRNA vaccine have really given people what seems to be a solid, durable protection against severe disease. There probably is some comparison, right? I mean, what percentage of people haven't had either 3 vaccines or 3 infections or 3 of some mix hybrid of these? But now, the easy thing would be, okay, you take a high-risk individual, a person who, despite vaccination, let's say a 90% reduction from 40%, still has a 4%, a 1 in 25 chance of ending up in the hospital. Okay, that individual, if they get a booster shot for 3 to 4 months, can drop their risk of even getting infected. They can drop their risk, hopefully, of severe disease. So that's really what you're looking with the boosters, this 3 to 4 month reduction. Now, when you get to the other end of the spectrum, let's say you take that 21-year-old healthy individual, they're low risk. They have a near zero risk of ending up in the hospital after those 3 vaccines. The push is a lot less. Are the 3 vaccines going to some degree reduce their risk of infection? Sure. At a population level, the more people that get vaccinated, the less transmission, great sort of public health. But usually people are asking from kind of an individual level. The other is we still see long COVID after acute COVID infections. It's low at this point. It's only a couple percent. If I told you had a 2%, 1 in 50 chance of winning the lottery, I mean, you might go out and buy a ticket. This might be your ability to not buy a ticket to get long COVID.
Margot writes, they gave my husband molnupiravir instead of Paxlovid, saying less side effects. What do you think?
So no, actually, it's interesting if you look at it, less side effects. We are trying to reduce the severity of the COVID-19 experience. We're trying to reduce the risk of ending up in the hospital, less drug side effects, but the efficacy of molnupiravir, it's not the same level as Paxlovid. Paxlovid is this 80-90% reduction. Molnupiravir, 30%. It's an inferior drug.
Mark says, you mentioned low cortisol level in some patients with long COVID. 1 in 7 Ashkenazim have a recessive gene of the mild congenital adrenal hyperplasia, which is greatly underdiagnosed. Please comment.
Yeah, so I mean, one of the comments that's just sort of making me think, so thank you for the question, right, is we talked about the fact that different cohorts of folks with long COVID have had different characteristics. So the Mount Sinai Yale group is where they saw 94% of their folks that are still coming to see them after a year had these low cortisol levels. Now, as we know, we're here in the Northeast. We have a large Ashkenazi Jewish population. So if you start looking at populations down, let's say at UPenn, or populations in the Midwest, where there's a different genetic background, you may not have the same finding. The publication at UPenn where they saw the low serotonin levels, they saw that in the UPenn cohort, they saw that in a Cork cohort, Ireland, but they didn't see it in a couple other cohorts they looked at. So sort of interesting, more questions to ask. Like if you sort of pin down the genetic background, the heritage of these individuals, is there some connection?
All right, we are 1 minute away from stopping here. Let's see. Let me scroll down here and see if there's anything we should highlight, like people who have donated. No? Okay. I think we will call it quits here. There's a lot of questions left, but Daniel and I have to go and record clinical update, which will take us almost another hour. So everyone thank Daniel, please, for coming tonight. Really appreciate it. I want to thank also our moderators. We had Les, we had Andrew, we had Tom, we had Frank, we had Steph, and we had Vanity Nutrition. Thank you all for making the office hours a wonderful presence. And we will be back next week. What is next week? Let's look at a calendar. Next
The
week.
10th of January.
Next week is January 10th. We'll be there at 8 p.m. And I don't know if I'll have a guest or not. We'll see. Keep you in suspense. Daniel, thank you so much for joining me tonight. I really appreciate it.
Thank you. Thank you, Vincent. And everyone, be safe. Happy New Year.
Everyone had great questions, I think. So thank you all for bringing great questions here, really thoughtful, useful questions for Daniel. We'll bring Daniel back next month. How's that? And you can resume your questions, assuming he agrees. But Daniel is generally very agreeable to coming on live stream. Thanks, everybody, for being here. Until next week, be safe. Bye-bye.